Welcome to the webinar. Hello and good morning to those of you in Western Canada and good afternoon to those of you in Eastern Canada. I'm Kathy Kyle. I'll be your moderator today. I'm a technical services veterinarian with Merck Animal Health, and last year with Merck's support and the Canadian Veterinary Medical Association, I spearheaded the Time to Talk about mental health and veterinary medicine campaign. And last year, September the 10th, 2019, we kicked off the campaign with an inaugural webinar in honor of World Suicide Prevention Day. Since then, we've had quarterly webinars, and we're back on September the 10th, 2020, with another webinar in acknowledgement of World Suicide Prevention Day. And the webinar is working together to prevent suicide in vet medicine. So the webinar does talk about suicide, and as the Center for Suicide Prevention reminds us, suicide can be personal and on the call today. And we do want to ensure that you are safe. So if during the webinar the information becomes overwhelming or distressing to you, please take a break. Take a deep breath. You can stop listening. However, do be mindful to get help if this is the case. And a good phone line to call is the Canadian Suicide Support Line at 1-833-456-4566, text at 45645, or go online to suicideprevention.ca for a list of crisis centers in your community. Most provinces, veterinary medical associations, do have a relationship with an employee family assistance plan provider. The list of phone numbers is available on the CVMA website under Mental Health Awareness Week, and that's a really good option as well. The EFAPs provide a variety of different types of support. It's confidential and anonymous. And then two, do consider your social network of family, friends, general practitioner, perhaps a spiritual advisor, people who you trust and can talk to. So we have 4 speakers today. First, we'll have Dr. Enid Stiles, our current CVMA president, to kick off the webinar. And then we have our 2 guest speakers, and I'll introduce each of them as we get to their area of the presentation. We have Dr. Elizabeth Spitzer speaking on suicide prevention in veterinary professionals through means safety. And we have Robert Olson, a librarian with the Center for Suicide Prevention, speaking on suicide prevention, safe messaging, and gatekeeper training. I will come back to launch the suicide safety sticker, and we'll be taking all the questions at the end because currently you are on mute and you will be remaining on mute. However, we do want to hear your questions and comments. So find the question mark icon and you can enter your question or comment in that icon area. Only I, as the moderator, will see your comment or question. And then I will moderate those questions back to Dr. Spitzer and Robert at the end. And I will keep everyone's names anonymous and confidential. You'll notice that you're seeing 4 panels on the screen. You can enlarge the panel by clicking on the maximize button in the upper right-hand corner and then click that button again to minimize it. The session is being recorded, and Lori Tarbett, who is an amazing communications and PR manager for the CVMA, is doing extraordinary work behind the scenes to update the CVMA mental health awareness part of the website with information, including the webinar recording, which will be available next week. And your CE certificate will be emailed to you. So let me introduce Dr. Enid Stiles. Dr. Enid Stiles graduated from the Ontario Veterinary College with a DVM in 2000. Prior to her veterinary degree, she completed a Bachelor of Science in Conservation Medicine at the University of Ottawa, and in 2009, a Master's in Clinical Sciences, Behavior Medicine at the Faculty of Veterinary Medicine, University of Montreal. In that same year, Dr. Stiles opened her own small animal practice, Sherwood Park Animal Hospital in the West Island of Montreal. It has grown rapidly and is now staffed by 4 veterinarians and offers a complete veterinary behavior service. And we are so honored to have Enid as our current Canadian Veterinary Medical Association president. Thank you, Enid, for being on the call today.
Thank you so much, Dr. Keel. That was a great introduction. And actually, I think it's the official first time that I'm speaking to our membership as the president. So this is a very exciting moment for me. And today is an important day for us to come together as a community to prevent suicides in veterinary medicine. And the CVMA is highly committed to health and well-being of their members and very proud to partner with Merck Animal Health in the Time to Talk About Mental Health in Vet Med awareness campaign. The discussion today on concrete methods to prevent suicides is critically important. And I believe that this is especially pertinent today with the high stress work environment we have with these COVID restrictions. And I can personally say that I feel this very seriously in my practice. More than ever have I ever felt that kind of stress. And I am significantly concerned about many of my team's mental health issues presently. Next week, I will launch the second episode of the Take 5 with Dr. Stiles, which are sort of short little videos available on social media and also links via our website. And I felt that it was really important to keep discussions of mental health on everyone's radar. And in such, this next episode talks about our struggles in practice and the importance of safe communication and ending the stigma of suicide. I am very much looking forward to this webinar, as I'm sure most of you are. So without much ado, I'll give it back to you, Dr. Keel.
And I will now move on to introduce our first guest speaker. And Dr. Elizabeth Spitzer has a PhD in clinical psychology from Auburn University. Liz is currently working at the Center for Healthcare Organization and Implementation Research at VA Boston as a Health Services Research postdoctoral fellow. Liz's research and clinical expertise are in the areas of suicide prevention and post-traumatic stress disorder, also called PTSD. She has examined suicide risk factors in a variety of groups, including U.S. veterans, veterinarians, and community samples. Liz co-authored the most comprehensive investigation of suicide amongst U.S. veterinary professionals and students to date, and the first to examine deaths by suicide among veterinary technologists and assistants. The research provides compelling evidence that access to pentobarbital might help explain the high risk of suicide and makes recommendations on changing the veterinarian's access to pentobarbital. Hello, Dr. Spitzer, and we're very honored and grateful to have you sharing your expertise today.
Hi, thank you so much for having me. I'm excited to be here. So as Dr. Keel said, I'll be talking about suicide prevention in veterinary professionals and a little bit about mean safety. So mostly I'm going to be talking about that author or that article that she just mentioned, and then also what we can do with the results and how we can translate that into suicide prevention efforts in our clinics. So although that was a great introduction, I just wanted to reiterate a few things. So one, although I am a dog owner to this very cute husky, I have no training in veterinary medicine. So when we talk a little bit about ways to implement this in clinics, I'd love to hear your ideas. I know that you all have much more experience on the floor than I do. Also, I'm US based, so I apologize if I use any acronyms that might not translate to Canada as well. Please just ask questions if you have them. We'll get started. So as I'm sure many of you are aware, veterinarians have an elevated risk for suicide compared to the general population, and that's a worldwide finding. And that's been getting a lot of attention in the popular press. However, we don't really know why that's the case. There's a lot of different explanations that have been proposed. And one particular factor that I'm interested in is the role that having access and experience with lethal means, such as pentobarbital, might play in explaining the elevated risk for veterinarians. So I want to start by talking a little bit about what we do know. So we know that occupations with access to lethal suicide methods have higher suicide rates. We also know that physicians who die by suicide are more likely than non-physicians to test positive for barbiturates or benzodiazepines. And we know that veterinarians are likely to have greater access to substances compared with physicians due to having less oversight and being in smaller practices. We also know that veterinarians who die by suicide are more likely to overdose than the general population. Some of the things we don't know, though, are what about the other veterinary professionals? Obviously, veterinarians aren't the only ones working in our veterinary clinics and hospitals, and there's really no research on veterinary technologists, technicians, assistants, other lab animal caretakers. And so all of these questions fed into the study that I'm going to spend a little bit of time talking about. So we had two primary aims. The first was to determine standardized mortality ratio for suicide among veterinary professionals, so all of those groups that I just mentioned. And we expected there to be an elevated suicide risk for all veterinary professionals compared to the general population. We also examined the role played by pentobarbital in suicide deaths among veterinary professionals. Again, for this, we expected the veterinarians to have that self-poisoning would be a top rate of suicide for them. However, we didn't make any hypotheses about other veterinary professionals because there really just wasn't enough data for us to base those hypotheses on. So where does this data come from? So as I mentioned, I'm in the US, so we were looking at a data set that comes from the Center for Disease Control and Injury Prevention. It's called the National Violent Death Reporting System. And so this allowed us to look at death records from 18 US states. So all of the states that you see in green from 2003 to 2014. So the darker states had more years worth of data. So we started with over 200,000 cases, and we narrowed it down to 189 cases of veterinary professionals and students who died by suicide. So we're really looking here at the 189 cases. So our main findings were looking at standardized mortality ratios for suicide. And before I go too much into the data, I just want to orient you to the chart a bit in case it's been a while since you've looked at statistics. So the dashed line at the 1.0, that's the standardized mortality ratio for suicide of the US general population. So if we were matching these people to similar people in the US, what would that look like? So for male veterinarians and female veterinarians, it's the first group we're going to look at. Where that vertical black line is in the middle of the bar, that's the confidence interval. So if that crosses the dashed line, it means it's not significantly different from the general population. If it doesn't cross that line, it is significantly different. So here we can see that male and female veterinarians, male and female vet technicians and technologists both had a higher standardized mortality ratio than the US general population. That was not true for male and female vet assistant or lab animal caretakers. They did not have a significantly different standardized mortality ratio from the general population. So the next thing we wanted to look at was the mechanism of death. And overall, there was no difference between occupations across methods. All three groups, poisoning was the most common method of death. However, within poisoning, pentobarbital was most common for veterinarians and was most often used by vets than any of the other groups. And because of that pentobarbital finding, we wanted to run some follow-up analyses. So one of those that we ran was looking at how the standardized mortality ratios changed when we removed the individuals who died by pentobarbital. So decedent just means someone who died by suicide. And so when we look at that, we can see that for male veterinarians and for female veterinarians, when we remove the individuals who died by pentobarbital, their standard mortality ratio for suicide is no longer significantly different than the general population, which really suggests that pentobarbital is one of the things that's increasing the rate of suicide in this population. The same was not true for female vet technicians and technologists. Another thing that the slide does not show here, but I think is a really important finding from our study, was that 72% of veterinarians who used pentobarbital as their method of suicide were injured at home, and less than 10% were injured at work, which means that these veterinarians are taking this pentobarbital home with them from the clinic. And so then the last thing we looked at was the history of suicide attempts in these groups. So we know from previous literature that veterinarians typically have higher rates of suicidal ideation or suicidal thoughts, but they typically have lower rates of suicide attempts. And that was consistent with our data too. So in our study, we found that the veterinarians were significantly less likely to have a history of a previous suicide attempt than the other two groups. And that's really important for prevention efforts, which I'm going to get to in a second. But just remember this finding if you can. So the big takeaway is that the most notable difference across occupational groups was the role of pentobarbital. So previous studies have shown that vets are at an increased risk for suicide. They're especially likely to use self-poisoning. Some have even shown that they're especially likely to use barbiturates. But this is the first study that's really been able to narrow it down to pentobarbital. It also, again, reiterates that finding that veterinarians are less likely to have a history of a suicide attempt, which might lead which might suggest that veterinarians are more likely to make a lethal suicide attempt on their first attempt because they have access and experience with these lethal means such as pentobarbital. And this finding is critically important for our prevention efforts. So it's so important that we understand what's causing this increased rate of suicide. And so although rather than focusing our attention on lots of different correlates of suicide, which are all very important still and risk factors, it's also important to narrow it down into this one thing that we can actually make some substantial change with. And one of the ways to do that is to limit access to lethal means like pentobarbital. So before we get too much into what that is, I'm going to talk a little bit more about just some general research on suicide and what is means safety and how does it work, and then we'll apply it to the settings that we're actually talking about. So it's important to understand that suicide attempts are often impulsive. And you might be wondering, like, what do you mean when you say that? So although people who go on to attempt suicide have typically had thoughts about suicide and maybe had methods in mind, such as using pentobarbital, or plans, which include not only the method, but the when, where, and how, in the days, hours, weeks, months prior to making an attempt, the actual period of suicidal crisis, so the actual time when someone is about to enact a suicidal behavior, is relatively short. So some studies have found that that period where someone's about to attempt or actually makes an attempt is less than an hour, and other studies have shown that it's less than 10 minutes. And so what that means is that window for us to intervene when someone's planning on using a lethal method might be really short. And if we're able to get someone past that window that's relatively brief, we can hopefully get them access to these other resources to help them build a life worth living and help them make life a little bit less painful and stick around. And so one of the ways to do that is by means safety. And we'll talk about different types of means safety in a second. But really the overall concept of means safety is restricting or limiting access to the most lethal means. And so in some cases that can mean pentobarbital. It can also be applied to things like firearms or building a safety net under a bridge. And oftentimes when this conversation comes up, there's immediate reactions of like, well, if you limit access to one type of mean, people are just going to do something else. And that's termed means substitution. But we know from research that that actually doesn't happen often. People typically aren't able to switch methods that quickly. And even if they are able to, if they use a less lethal method, they're more likely to survive. So if we can prevent that most lethal method, even if they do substitute it with something else, it's likely to be less lethal and they're likely to survive. And we know that people who survive a suicide attempt, less than 10% go on to die by suicide. So if we can get them, again, past that short period of crisis, we really have hope for this being a life-saving measure and something that can continue on. It's not just a short-term fix. So I'm going to talk about one example that, if you hang with me, I promise I'll make it applicable to this setting, but it might sound a little out there first. So in Hong Kong, charcoal burning was a really rare method of suicide. So about 2% of the population who died by suicide died by charcoal burning. And then a woman died by charcoal burning, and the media in Hong Kong really sensationalized it, essentially broke every media reporting guideline for suicide. And all of a sudden, charcoal burning shot up and became the third most popular method of suicide and accounted for 26% of all of the suicides in Hong Kong. So some researchers went in and decided this would be a good way to test some means safety. So they looked at two neighboring regions in Hong Kong that were pretty much identical in terms of all of their demographics. And the only change they made was that in one district, you still could go into any store and just buy charcoal off the shelf. And in the other district, it was required to be behind the counter. So you didn't have to show an ID. The wait time was less than 10 minutes. It was really easy. You just had to ask for it behind the counter. So you had to interact with another person. And just that small intervention, where you were still able to access it, but there was a barrier in place, significantly reduced not only the charcoal burning suicides in that one region, but also the overall suicide rate. While in the other region that had no intervention, the suicide rate actually went up a little bit. So we can see how even these really small changes can make an effect on the overall suicide rate and really save lives, which is the goal. So you might be thinking, like, why does this, like, we're not talking about charcoal burning, and how does this apply to veterinarians? So we could apply this to veterinarians, right? So when we're talking about means safety for veterinarian professionals, we're talking about the safe storage of euthanasia solution, like pentobarbital. And I want to acknowledge that different approaches will likely be needed across different veterinary practice settings, right? A huge hospital and a small clinic are going to have different needs, and that's okay. And so when we're talking about this, it's really important to think about what are the different types of means safety. So there's really 4 different levels, and there's only one that's applicable to vet settings, or when we're talking about limiting or finding ways to put some barriers in place for pentobarbital. So the first is called elimination controls, which those would be physically removing the substance. That wouldn't make any sense here because you need pentobarbital to do your job. In the same sense, there's substitution controls, which involve replacing the lethal method with something less lethal, like they did with catalytic converters in England. Again, that doesn't make sense because you need it to be lethal for euthanizing animals. There's also engineering controls, which would involve isolating people from the substance, so like restricting people from having any access to pentobarbital, or again, that doesn't make sense, you need it for your job. So the only type of control left is administrative controls, which involve changing the way people work. And that's really the most viable option we have here. And so when we talk about that, one particular way that's come up a lot is called the 4 Eyes method. And so this can be implemented a lot of different ways. And I'm actually really excited and interested to hear if any of your clinics or settings have implemented any of these things, how they've worked, if you have ideas. So the idea of the 4 Eyes method is that 2 people must be present to remove pentobarbital from the safe storage. And that can look like a lot of different things. It might be 2 unique ID cards, 2 unique fobs, 2 unique keys. And one of the things that often comes up is, like, if we're talking about things like fobs and keys, where are those being stored? Are they just hanging on a hook at the front desk where anyone could grab to? Or are they genuinely, like, everyone has their own and it's really, people are really following the guidelines? And part of this is really getting key stakeholders involved. So when you're making these regulatory changes, having discussions with your clinic about why you're doing it. Because the idea here is that we want to save the lives of our coworkers, our friends, or even ourselves. And so making sure that people understand that this isn't just another hurdle. We're not trying to slow down your work. We're not trying to make the day harder. We're trying to make sure that everyone is safe in the environment and safe when they go home, since we found that most veterinarians are actually taking this home to die by suicide. And so really getting that buy-in from everyone in the clinic. I also want to mention that means safety is not the only suicide prevention strategy. So up next, Robert's going to talk about Gatekeeper Training, which is a great way to get other people involved. We're going to be talking a little bit about, like, media campaigns and increasing knowledge and awareness of suicide resources. Dr. Keel is going to be presenting the sticker at the end. Also, increasing support and access to mental health care. So we found, or there's literature to support that veterinarians actually have an increased stigma towards mental health, seeking mental health resources compared to other professions. So really normalizing that it's okay to seek help. It's a sign of strength, making sure that people feel like they have the time to take time for themselves, time for their mental health. And then lastly, things like safety plan training, which I think there's going to be a webinar on in the future. So highly recommend that you all attend that. But all of these can work complementary with means safety. So thank you so much for listening. I do want to just have a quick disclaimer about my data. All the views were my own, and acknowledge my other co-authors and those who helped on this project. But looking forward to hearing your questions at the end, and I will give it back to Dr. Keel.
Wonderful. Thanks, Dr. Spitzer. And now we'll transition to our second speaker, Robert Olson. And Robert has a BA and Master in Library and Information Science. And Robert works as the librarian at the Center for Suicide Prevention since 2011, where he leads the knowledge translation efforts produced by the center and helps manage the largest English language library collection on suicide information in the world. From the collection, Olson and his team disseminate the information through secondary research publications, including resource toolkits, opinion editorial articles, special features, fact sheets, infographics, and webinars. Robert sits on several suicide prevention-related committees, participates as an expert panelist on public forums, and gives media interviews as a source for suicide prevention information. Robert also performs library services, including literature reviews and rapid reviews. This work has resulted in various outcomes, from being included on the Canadian Institutes of Health Research, CIHR applications, for large-scale research projects, to conference speaking invitations, to informing government policy. So with that, I welcome Robert to the webinar, and grateful to have you here sharing your expertise and knowledge.
Well, thank you so much, Dr. Keel. As Kathy said, my name is Robert Olson, and I'm with the Center for Suicide Prevention. Thank you all for attending today's webinar. I'm going to address two different topics today that may seem quite different upon first glance, but are in fact quite interrelated. I tried to weave them into a coherent presentation. First, I'll talk about the importance of safe messaging in suicide prevention. And then I'll follow this by discussing the utility and efficacy of using suicide prevention gatekeeper training, in particular the assist training, to help someone at risk of suicide. However, I'd just like to start by briefly stating, how is it that people even get to the point where they consider suicide as an option? Suicide is complex. People who kill themselves are often experiencing immense psychological pain, and they are often ambivalent about living or dying. They don't want to die, they just want the pain of living to stop. They can't see anything outside their cognitively constricted view, a tunnel vision of sorts, and no other option seems possible. Loved ones and those left behind after a suicide often ask, how could they have been so selfish to take their lives? This description of the suicidal state of mind goes a long way to explain the act. Thoughts of suicide dominate and don't often allow for any other kind of thinking. Which loops us back. How can we help those at risk? We can help by creating safe spaces, by building an environment of trust. We can do this by communicating openly, directly, inclusively. Safe messaging about suicide allows this to happen. Once we've established a safe and trusting space, we can be there to offer help with what we have learned through Gatekeeper Training. So, excuse me. First, safe messaging. Public communication about suicide is hugely important. Whether it's a newspaper account of a celebrity suicide, or the words on the suicide prevention sticker that Dr. Keel will be talking about later on. Unsafe or improper communication and other forms of misinformation can actually undermine positive suicide prevention efforts done elsewhere, and it can, in fact, be harmful to people at risk of suicide. Often sources will have conflicting facts about suicide or contain misinformation or myths. This misinformation and inconsistent messaging helps to perpetuate stigma by undermining the accurate information that is out there already. Messaging about suicide must be consistent and must be authoritative. Also, people already at risk for suicide are particularly vulnerable to unsafe messaging. Reporting on a suicide, for example, in glamorizing terms can create contagion. Or highlighting or describing in detail a particular method of suicide can cause copycat behaviors in those predisposed to suicide. It can conjure in their minds an indelible image to imitate. Yet, we also know that conversation about suicide is extremely helpful, especially in terms of the reduction of stigma. Stigma is the #1 barrier to someone seeking help. Safe communication about suicide erodes stigma and lays the foundation to build a trusting relationship. A relationship where people at risk feel safe to talk about difficult issues, including suicide. This is a setting where we are more likely to ask someone someone about it or to seek help ourselves. Conversely, a reduction in stigma encourages more conversation. Both practices reinforce each other. Messaging about suicide has some do's and don'ts. I've listed some here which pertain to suicide reporting and to public messaging about suicide. If you look at the list of do's, you can see that a number of them suggest positive actions to take. Emphasize help-seeking actions, listing where help can be found, including messages of hope and stories of resiliency if possible. Research shows that messages promoting positivity have a greater impact on the reception of the prevention message. On the to avoid side, in addition to the ones I talked about earlier, glorifying suicide or describing the method, we should always avoid the idea that suicide is inevitable or beyond explanation, or to oversimplify suicide. For example, often we'll see stories linking bullying as a direct cause to suicide, or more recently, some stories in the media are linking the stress of COVID-19 directly to suicide. This implies suicide is an inevitable reaction to a given situation. We know that there is not a direct causal relationship between either of these and suicide. Correlation, yes. Causation, no. A very important point to avoid is stigmatizing language. Some words and phrases used to describe suicide can unintentionally and unwittingly reinforce stigma. For example, committed suicide denotes criminality, as in committing a crime, further stigmatizing the person who died. Use die by suicide or death by suicide instead. Or completed suicide, successful suicide, or failed suicide attempt paradoxically use a positive slant when somebody dies and a negative one when an attempt does not result in death. Instead, use phrases such as non-fatal suicide attempt or simply suicide attempt. In general, we can help facilitate safer communication by selecting more neutral, non-judgmental, and compassionate words and phrases to talk about suicide. So, a safe environment has been created, one where you feel comfortable talking about suicide with someone you're concerned about, and they likewise feel comfortable in fighting with you. What do you do now? This is where I'd like to pivot to talk about gatekeeper training. There's a misconception that only professionals can help those experiencing suicidal behaviors. In the early 1980s, a group of Canadian academics, sensing a need, created a community-based intervention training in suicide prevention. Their approach was heavily influenced by the work of clinical psychologist John Snyder and his seminal ideas regarding the unique qualities and contributions of gatekeepers in times of crisis. Snyder simply defined a gatekeeper as any person to whom troubled people are turning to for help. This was a revolutionary idea in the mental health field at the time, that people in the community, everyday people, could actually help those in crisis. There are many good and efficacious suicide prevention trainings available today. But those Canadian academics I referred to on the previous slide created the first suicide intervention workshop in the early 1980s. It came to be called the Applied Suicide Intervention Skills Training, or ASSIST for short. It is continually updated, incorporating new research and the current best practices. It's now on version number 11. It's the only gatekeeper training that boasts positive outcome measures at 3 different levels. At the level of the helper, the person at risk level, and at the community level. It is on every global English language best practice registry, including the Public Health Agency of Canada and the Suicide Prevention Resource Center in the United States. It was the first, and is still, in our opinion, the best training available. Assist differs from other programs which essentially teach participants to identify someone at risk and then send that person off to professional help. This is often described as a referral type approach. Instead, Assist teaches participants to recognize and to intervene when someone may have thoughts of suicide and work with them to create a plan that will support their immediate safety. What truly makes this training unique is its guidance of participants through value identification exercises, allowing them to reflect on their own beliefs about suicide. This step helps us understand our own approaches to helping others and can unearth our own prejudices. It's an opportunity to consider any discomfort we may feel about suicide. It addresses the issue of stigma from the get-go, stigma which we may hold within ourselves. As mentioned earlier, stigma remains the single most significant barrier to suicide prevention. Much of the appeal and success of Assist rests with its fundamental belief that anyone can have thoughts of suicide, and anyone in the broad range of helping roles from layperson to expert clinician has the capacity to help someone at risk of suicide. This philosophy underpins every aspect of the workshop. And ideally, participants leave the workshop willing, ready, and able to respond to someone at risk. In summation, we can all play a role in the prevention of suicide. Whether it's helping to carry safe and accurate messaging, allowing for a conversation to occur, or going further and having a caring conversation with someone at risk, allowing them to reach a place of safety. We can all contribute, as suicide prevention is everyone's business. Thank you very much.
Thank you, Robert. And just a reminder that the Center for Suicide Prevention's ethos is We Educate for Life. And the Center for Suicide Prevention is also in association with the Canadian Mental Health Association. So a few more notes, and then we'll open it up to questions. And thank you. We have lots of questions. So Robert mentioned Gatekeeper Training, and I do want to make sure that you are aware that there is online veterinary-specific suicide prevention training. Banfield Animal Hospital, in association with the American Association of Suicide Prevention, developed this 30-minute online training last year. They're making it available free of charge to all veterinary professionals in North America. So the URL is at the top of the screen. It's vetfolio.com and then /courses. It's called Ask, Assess, Support, and Know. And just a mindful note of caution, it is self-directed learning. So try not to listen to it on your own. Be with another person, because it is possible to have an adverse experience looking and hearing the information. And better still, if you're a clinic owner or an office manager, set aside a lunch hour to have everyone watch, ask, and then have a conversation around how people are feeling, ensuring that they do have access to Employee Family Assistance Plan or other resources, and then open up a conversation based on what we heard Dr. Spitzer say with respect to what does your clinic need to do differently to ensure safe storage and usage of pentobarbital. And then, as Dr. Spitzer mentioned, with respect to mean safety, and Dr. Spitzer talked about administrative controls, I am really thrilled to launch the Suicide Safety Sticker. So this sticker is available for free download from the CVMA, and it has messaging developed by the Center for Suicide Prevention. And the messaging is straightforward, it's compassionate, and the hope is that if someone is in distress in the clinic and reaching for pentobarbital, they'll see this sticker and they'll pause. And in the pausing, realize that help is available. So it does, there's an English version and French version, so it directs the person to the Center for Suicide Prevention phone number. And I think the images on the sticker are really impactful, because it shows that there is a helping hand. There is someone who is trained to listen and to help and support hear the story. And the people who are trained on the suicide crisis phone lines won't dismiss, they won't ignore, and they won't minimize the story that we have when we are in distress. So I encourage all of you as homework after the webinar, download the sticker and print it out on adhesive paper so that you can stick it on your drug safe or place it at various spots in your clinic so that, you know, there's not one single winning solution to prevent suicide prevention, but I think this is a really good tactical and accessible one. So I'm now going to open it up to questions, and I was kept quite busy, thank you, with all the questions that were coming in. As Dr. Spitzer and Robert were speaking, I've sort of compiled the questions together. So I think the first one we'll take is around the 4 eyes approach. And I heard from one veterinarian that they do use the 4 eyes approach. This is at a veterinary teaching hospital when RVTs or students are withdrawing the euthanasia solution, and it's working well. However, there was a question on if someone is planning to use pentobarbital to suicide, then they may draw more than is needed and withhold the extra. So the storing of the euthanasia for the planning of a future suicide. So maybe I'll put that back to Dr. Spitzer. If Liz, you have any ideas on that?
Sure. Yeah. So the 4 eyes approach can accommodate a lot of different things, and so some also suggest not only when you withdraw the pentobarbital from wherever it's being stored, but also having 2 people present. And again, it doesn't have to be 2 veterinarians. It can be a veterinarian and assistant present for when it's also administered and when it's properly disposed of. So making sure that that whole process is being monitored. I know that that's not always possible in every clinic, especially much smaller clinics, but trying to find ways that work, or, you know, making sure that however it's being logged or however it's being administered and then disposed of is actually something that you can track and make sure is actually happening as it should be.
Thank you. And then on the 4 eyes method, Liz, a number of solo ambulatory practitioners or food animal practitioners, equine practitioners who are going out to calls on their own and likely have a drug safe in their vehicle. What can they do with respect to staying safe with the euthanasia solution, given that the 4 eyes approach wouldn't be applicable for them?
So I will say I don't know much about how all of those practices work, being a sole practitioner. One example that comes to mind is, so in the US, obviously a lot of means safety talk is around firearms, as you might imagine. And so one example that we typically talk about with firearms is that in the Israeli, the IDF, their Air Force, they only allow, they don't allow soldiers or service members to take weapons off base with them. So they're only allowed to have them on base. And so I don't know if there's something similar where like, there's a way that you can't access the truck when you're not working, or how that works, where the truck is parked or stored after you're on calls. But trying to think of creative ways to still limit the access when you're off duty and when maybe you're alone and feeling like it's a harder day, but still having access when you're on those calls and needing to do your job. Again, also really welcome other creative ideas from people in the field who have a little bit more experience with what that type of job looks like.
Right. I'll keep monitoring to see if anyone has suggestions. So if you do have suggestions on how perhaps your practice with solo practitioners have implemented the 4 eyes approach, please put that in the question area. I think too, Liz, to your point, having those creative conversations with other members of your clinic, with that brainstorming, there may be a way to help provide the correct access to pentobarbital to do the work that veterinarians need to do, yet still ensure safety. I also thought too about the fob system. And I think in human hospitals, some of the fob systems are connected to computers so that the fob usage can be tracked. So if there is unusual activity around when someone is using a fob to access the pentobarbital, perhaps on off-duty hours, then that could be a possibility too, just to be able to alert the rest of the team that something might be unusual in order to then have a conversation to help that person.
I think that could be great. Obviously, that requires access to more technology, and I don't know if that's like feasible for everyone, but even just having an alert anytime it's accessed where it alerts someone else where they could kind of like approve or deny even if they're not on site, I think would be great.
Okay. Yeah, definitely an area for more conversation and perhaps some different ways to implement the 4 Eyes in those practices with solo practitioners or out doing farm calls or equine calls. One comment on the 4 Eyes approach, it was positive with respect to this is an excellent presentation. And previously I've been a naysayer of the 4 Eyes movement. And Dr. Spitzer has shut down all my reasoning. And by providing the statistics, our registered veterinary technologist is reconsidering the 4 Eyes approach in a very busy practice. So I think I heard, Liz, you wanting to hear from anybody using 4 Eyes. So I think we got a healthy feedback on that. I did receive a question, or we did receive a question on hearing that there are short windows of crisis and intervention, at the same time noted that most suicides are done at home, or at least with pentobarbital. And how do we reconcile the two?
Yeah, that's a great question. So that really highlights one of the things I was saying before of even if we can limit the most lethal mean, which in this case is pentobarbital, even if someone chooses in that impulsive moment to enact some sort of suicidal behavior, if they don't have access to pentobarbital, they're much less likely to die by suicide. And so we can still, even if that crisis is happening at home, if we can prevent them from taking the pentobarbital home with them and having that preparatory behavior in the clinic of getting a very, very lethal mean home, or as well as other opioids and things like that, I think that's where this comes in, and that obviously I don't want to talk about too many different types of suicide, but like cutting, for instance, has a really low incident rate of death. And so like if someone's substituted with cutting, which is like more commonly seen in, like Netflix shows and things like that, they're more likely to live, and then we can help them. And so really the goal here is to limit the access to the most lethal means. And in this case, it's one that doesn't have that many restrictions around it compared to other things.
Okay, thank you. Robert, anything to add to that from your perspective with the Center for Suicide Prevention?
Well, exactly. To delay or to take advantage of that window of where impulsivity can be the driving factor in someone dying by suicide. So means restriction in any way will allow someone, I guess, without, unintentionally to have that pause, to have that second thought and maybe not go through with the idea. So any kind of removal of access is crucial. So in pentobarbital, sorry?
No, finish, sorry.
Oh, go ahead. No, please.
I was just going to say, like, I think another big thing is that pentobarbital is, I think, often seen as a pretty painless and quick way to die. And if we can remove that, which might be more, it might look more appealing for someone who's feeling extremely suicidal. If we can remove that method, they're much less likely to try a more painful or prolonged method. So really limiting that access to the most lethal and what can be seen as like the most easy method can really make a large impact. And again, substitution is really rare. So people often don't switch methods. And so like Robert was saying, if we're able to limit the access to the mean, it really can have a large effect on all suicide rates, not just that one type.
Mm-hmm. And Robert, thinking back to the Gatekeeper training that I've taken with the Center for Suicide Prevention, so Safe Talk and as well as Assist, and I'm certified to teach Safe Talk, I think some of the things that I've learned from suicidology experts is that suicidal thoughts come and go. And we can't prevent someone from having suicidal thoughts. It's part of being human. Certainly some people are more perhaps predisposed to having them than other people, but it's the acts of suicide which we can prevent. So the thoughts, I guess the planning, that all might happen, come and go, whereas the impulsivity is more around the actual event of choosing a means and then choosing to die by that suicide method.
Exactly, and the more people who are educated about what to look for in someone who may be experiencing suicidal behaviors, as well as being receptive to someone reaching out, allows, as I said in the presentation, that caring conversation, dialogue to take place, which often will eliminate a crisis point as well, and function in the same way that accessibility to means, So yeah.
If I notice that someone has some signs that potentially could point towards suicidal thoughts, so maybe saying things like, I just can't take another day like this. And if I was to ask someone that question, would I be putting the thought of suicide in their head?
Oh, absolutely not. Talking about suicide, that's one of those myths I was referring to, and it's commonly believed wrongly that talking about suicide with someone will plant the idea in their head, and nothing could be further from the truth. If someone was thinking about suicide, they would be already. You're not going to put the idea in their head, and in fact, bringing it up with someone who may be experiencing ideation will be often a relief for them, and they can, I don't want to use the word vent, but they can, talk about it and sometimes steer away from a crisis.
Yeah,
so
feel unburdened.
Communication. Yes, definitely. So communication is key, as I was saying earlier. But yeah, it's one of the, there are several myths, so, pertaining to suicide that are out there, and that's definitely a major one.
And the good thing is that taking Gatekeeper training like Safe Talk or Assist helps to bust through those myths. And I did see one question about the Assist training and whether that was the same as the Ask training, which is available on the vetfolio.com website. And the two are different. So the Assist is face-to-face. It's a 2-day workshop. It's excellent. I've taken it, and it helps you become an interventionist, so someone who can help keep someone safe who does have thoughts and a plan of suicide. Whereas the Vetfolio ASK is a 30-minute online suicide prevention training. It's very good training, but it's certainly shorter. And then a question I think for you, Liz, is, are there any stats on suicide rate as well as suicidal ideation in veterinary students?
So I actually am trying to get a paper published on veterinary students right now. There isn't any data on the rates of suicide in veterinary students. We included veterinary students in our sample, but there was less than 5. And because of the way the CDC allows us to publish data, we couldn't include that in the charts. But there is a lot of data about suicidal ideation or thoughts about suicide, which is high in veterinary students, which is not dissimilar for other advanced graduate programs. And there's a lot of theories, again, around why that might be. One, veterinary programs, at least in the United States, I imagine it's similar in Canada, are really competitive, and they don't necessarily always encourage a collaborative environment because, like, the top of your class are getting, preferred spots in different residencies and things like that. Also, just like the amount of pressure, the financial pressure of maybe debt and things like that. One of the things I know, like at Auburn's veterinary program, they have an individual provider that just provides mental health services for the veterinary students, and that's free of charge. And they really have done a great job of a lot of like messaging and things like that to encourage mental health care. Also, like I guess it's not Gatekeeper Training, but there is an app called Virtual Hope Box, which allows you to not quite make a full safety plan, but it allows you to kind of capture different reasons for living that you might have and have a reminder on your phone. So even encouraging students to have something like that they can look at, or these sole practitioners that, maybe having a reminder of like what is important in their life to stick around for can also be helpful. And then I think just starting to have these conversations early that, this is a profession that has increased stresses and has lots of risk factors above and beyond the access to pentobarbital that might make them susceptible to having increased suicidal ideation and eventually maybe attempting, and encouraging them to seek help, to do these trainings, to learn about safety planning and be prepared for that as part of the profession. And not just for themselves, but also to help their coworkers and colleagues.
Thanks. That segues into another comment. Speaking of stressors for veterinary students, one student had typed in that with COVID and the inability to see classmates live, and a lot of the lectures are online, what are some ways to better look after one's mental health in the time of COVID and spending a lot of time online? And I think you gave very good suggestions, Liz, that could apply to that scenario too. As I was thinking for this student, to reach out to the counseling group that would be on campus at that university, maybe not specifically for the veterinary students, but counseling for people in general around these times of stress, and have that counselor come in and do a webinar for the students on some techniques. And then techniques that I had in mind too is exercising. Even just 15 minutes a day helps to burn off restless energy and reduce stress levels. Some mindful breathing as well. And perhaps the students could encourage their profs at the beginning of online lectures to take them through a 30 or 1 minute breathing exercise. A simple breathing exercise is breathing into a count of 4 and holding at the top of the inhale for a count of 4, exhaling to a count of 4, and holding the bottom of the exhale to a count of 4. So doing box breathing definitely helps to reduce stress. And then I think too, social media, just having some limits on how often one is on social media, particularly if they're spending a lot of time virtually on webinars to learn their academic work. Anything to add to that, Liz or Enid or Robert?
I think those are all great. Also, just anything that you enjoy, even if it's like making a cup of tea or going for a walk, doing something that like petting your dog, doing something that you find enjoyable and distracting that can kind of shift your mood, I think is important. And then with the social media, also being careful not to compare yourself to how other people seem to be doing during COVID or how your classmates seem to be doing, and just recognizing that people put their best selves on social media, and that's not always a representation of, what they're going through too. I think we can all, especially students, get caught up in that of like seeing classmates doing their very best and forgetting that we're all struggling right now.
Mm-hmm. Thanks.
And also, yeah, I think to try to maintain your social connections as best as you can. And again, I don't mean social media, but those meaningful relationships that you have. So.
And Enid?
Yeah, I just wanted to sort of highlight that aspect that within practice, I think it's very important for everyone to realize that we are really all facing similar struggles with respect to COVID, but that everybody's at a different place in their own lives and may be struggling more than another, or differently, I should say, than another. So to keep that, being mindful of that when you're working with others, and also to be mindful of that when you're working with people who may not be happy clients or very stressed, because they are definitely treating some of us not always with respect. And I think that comes back to their very own stress levels, which are heightened right now with the COVID situation.
Thank you. Yeah, very well said, all three of you. So we're coming up to the hour. And so if people do have more questions, the email addresses are on the screen of Elizabeth Liz, Robert, and myself. And I just do want to finish it off by reminding people of the next webinar, which will be November the 19th. Robert is coming back to talk about the Suicide Safety Plan Toolkit, which will help us better understand what we can do to help create a safety plan, similar to what Liz mentioned about the virtual hope box, to help keep someone who is having thoughts of suicide safe from harm. And there's also an important time to hear the story of people who have the lived experience of both suicidal ideation, so having thoughts of suicide, and having attempted suicide. So we're going to give space to hearing some people in veterinary medicine and also outside of veterinary medicine to share their story. And then if you don't hear this enough, or if you don't hear this today, you are amazing. You're deserving and you're worthy of taking care of yourself. So do take a deep breath and have a good rest of the safe World Suicide Prevention Day. Thank you for joining us. And we'll all stay on the line for another minute or two. But if you do need to jump off, it's now after the top of the hour. Again, I thank you for joining, and I thank Liz and Enid and Robert for sharing their wisdom and expertise and creating the social connection that this webinar provides. Take care.
Bye-bye.
So the last comment that came in that I didn't have a chance to speak to was from a student, a pre-vet student, wondering if she could cite the webinar because she is writing a paper on suicide in veterinary medicine, and the paper's been nominated for an award, and she wanted to make sure that she could add any appropriate citations. So absolutely, you can cite the webinar. And then Dr. Spitzer's research is published in the Journal of the American Vet Medical Association, and I believe it was September 2019 when it got published. Good, and I'm just going back up through the comments, and it looks like we've answered and addressed them all.
Nice.
Yeah, so thank you all. And in total, we had 146 participants.
Awesome.
Yeah.
How does that rate with previous ones?
It knocks everything out of the park. It was great. Yeah.
Oh, nice.
Yeah. Yeah.
Good to know.
And yeah, and absolutely. And the 146, oh, we're time to say goodbye. Okay. Thanks all.
Thanks.
Bye-bye.
Thanks, Kathy. And thanks, Liz. Thanks. Bye-bye.
Thanks. Bye-bye.